caudal epidural has been published already in the last issue of Pain Physician. We found about 73 studies and 51 were excluded. 16 studies met the inclusion criteria for quality assessment with 11 randomized trials and 5 non-randomized studies. So based on only the fluoroscopic studies, not non-fluoroscopic, all the old studies like Dana was describing, those are outdated and worthless. So we didn't even include them in the evidence synthesis this time. We just included the fluoroscopic studies. So there was good evidence for short-term and long-term relief. That is, 6 months is short-term. Long-term is more than 6 months. That is what we defined here. Secondary to disc herniation or radiculitis, either with local anesthetic and steroids, that is good. But if you used only local anesthetic, it was fair. When we looked at the other conditions, we looked at condition specific. That is extremely important, how you included the patients, and is it disc herniation or stenosis, post-surgery syndrome. The evidence was fair with using that strict criteria I showed you before for caudal epidural injections in managing chronic axial or discogenic pain where you ruled out facet joint and SI joint pain. And in spinal stenosis, this is fluoroscopic caudal and also post-surgery syndrome. Now, we really looked at this big evidence philosophy here. The Iverson did the randomized trial without fluoro. They used the ultrasound, and they are saying, so the next thing to kill interventional pain management is ultrasound. Everybody will be doing them everywhere, in every corner, and it will be done. I'm not the closest-minded person in the world, but we really need to look at important aspects of life. If you want to be an interventional pain physician, you want to do ultrasound, epidurals under ultrasound, nerve blocks under ultrasound, I don't know. I really question about that. So their study showed there is no effect at all. And that is the study everybody is going to use now. They're all running with it. It was published in British Medical Journal. So we did a competing study with active control design. We showed that it does work. And there are lots of other people, Ackerman Ahmed, and in our study, there was no significant difference between local anesthetic and steroids except at 3-month level. At 3 months, patients did do better in the steroid group in the disc herniation, but not after that. And we used the stricter criteria, 50% pain relief and also 50% functional status improvement. We didn't use like 1 point difference and 2 points difference. When you use those irrelevant stuff, you can't really judge if the treatment is working or not, and then you get criticized. So you have to have a robust standard criteria. Ackerman Ahmed, it was a short-term study. They showed positive. Dashfield, this is the one they use always as a negative study. What these people did was they wanted to look at the spinal endoscopy in patients who never had surgery. Why the hell do you want to do a spinal endoscopy in patients who never had surgery? My endoscopy article I submitted to anesthesiology, and they blasted me. How stupid I was. I took the patients who had post-surgery syndrome, I did it in them. I should have done in virgin backs who never had any treatment. Why do you want to do those things? Why do you want to expose patients to that kind of risk? But the thing is, Dashfield showed that endoscopy patients did worse because you traumatized. There was nothing there, and you put the scope and all the damage, everything. But the patients in the control group, only received a caudal epidural, they did better. So they had positive results. So they don't want to use that study to show the caudals. I'm using in reverse manner. It is negative for endoscopy, but positive for caudal. Then there are a lot of these few other studies. This is the axial pain without disc herniation or protrusion, or without radiculitis, without facet joint pain or SI joint pain. You need to be careful when you just say that, just start doing epidural and call it axial pain. Any low back pain is not axial pain. Somebody can have a huge disc herniation, and at that point of the evaluation, they may just have low back pain. Eventually, they will develop the leg pain, but they didn't develop at that time. So we eliminated all the patients with disc herniation or even disc protrusion. And if they had facet joint, we checked them for facet joint pain and looked at it, and we had positive results. At 12 months, 84% of the patients were better with 3 epidural injections over a period of 1 year. Results of observational studies in managing randomized and observational. Spinal stenosis, also there is not much literature. Again, I hate to keep mentioning my own name, not that I like listening to my own name, but that was only the study, the spinal stenosis. We did the study. And in this, you see, compared to the others, the results were not that good. In spinal stenosis, only 48% and 46% when you took the overall results. But if you selected the patients who were failed, first 2 injections, if they fail, why are you going to do them? We considered them as failed group if they received less than 3 weeks of relief with the first 2 procedures, which is a very, very weak standard actually. Originally, I wanted to exclude everybody who had less than 6 weeks, but then we changed by the time we wrote the protocol. So even with that, if you exclude those patients who don't respond for first 2 injections, don't go and do a 3rd one, 4th one, 5th one, our results were much better. Even in this group, it was 60% of the patients did better. And there was another small study, and this one is a retrospective study, pretty large, but it had a positive results. Managing post-surgery syndrome. Caudal epidural, again, we did the positive study, but this one was about 56% good results at the end of 1 year. So post-surgery syndrome patients may do better than spinal stenosis actually, according to this. But there was no difference between steroid or local anesthetic. And then you have these other randomized trials, the older ones. It was a low-quality study, but still had positive results. Therapeutic lumbar transforaminal epidural injections. We found 70 studies, and a total of 27 met the inclusion criteria. There were 15 randomized, but it's only 13 because there were 2 duplicate publications and 10 non-randomized studies. So the evidence is good for radiculitis secondary to disc herniation with local anesthetic and steroids. But if you inject only local anesthetic, it is fair. It is fair for radiculitis secondary to spinal stenosis with local anesthetic and steroids. And it is limited for axial pain and post-surgery syndrome using local anesthetic with or without steroids. These are the results of the studies. Transforaminal epidural injections. Bogdok was one of the co-authors in this. They did really do a good placebo injection in this. They injected sodium chloride solution with contrast into the muscle, not into the nerve, not into the epidural space. That is a good placebo design. Whereas caripinol was a lousy placebo design. He went ahead and put 2 cc of sodium chloride solution over the nerve. That is a lousy design. So randomized active control, there are multiples of them. Luckily, we didn't do any studies on this yet. So. There are lots of studies there, and they are also non-randomized. Fortunately, you can't do this without fluoroscopy, so there were not that many non-fluoroscopic studies. You can't do transforaminal without fluoroscopy. We did exclude all the ultrasound studies. These are more of them. then that was the disc herniation. Now we go to the spinal stenosis. There are lots of studies even on the spinal stenosis also. And there is fair evidence for that. And we didn't look at transforaminal and post-surgery syndrome. Like Dana mentioned, transforaminals are pretty high-risk procedures. And one of the issues related to there is the risk is much higher in post-surgery syndrome because of the scar tissue, disturbed anatomy, and everything else. So we didn't even look at that. We just said, no, forget about it. Sacroiliac joint interventions. The evidence is fair for cooled radiofrequency. Now there are 2 studies. When we published our study articles and ASIPP Guidelines, there was only 1 study. Now there is a second study by Dr. Patel. Both are positive, so borderline positive. So the evidence comes to be fair. But it is poor. We should have used a word limited on there, but that it is already gone. We can't do anything. So effectiveness of intra-articular steroid injections. Again, it doesn't tell you that you should not use. There is emerging evidence. There is more evidence coming. Peri-articular injections, injecting around the joint may be better sometimes. Some of the studies show better results for that, but there is no evidence level for that. Conventional radiofrequency neurotomy, there is not much evidence. Pulsed radiofrequency, no, not much evidence. So these are the tables showing, this is a good study, Hawkinson, Schoferman. The problem is that it is a retrospective evaluation. It is a non-randomized. So the evidence is okay, but you really don't reach fair level. It has to be a randomized trial, at least one randomized trial. So if you get refused so you can turn around and show them these articles themselves that there is emerging evidence, it is coming up. Until somebody does a good study, cooled radiofrequency neurotomy, those are the 2 studies, Cohen and Patel. Thermal annular procedures, there is only evidence is fair for IDET, but everything else is poor. But Stan Helm did this review, and he wanted that everybody to know there are 2 studies coming for disc trode and biaculoplasty. Those are the details. Now, sacroiliac joint interventions, the diagnostic accuracy. There is good evidence for diagnostic accuracy of diagnostic sacroiliac joint injections. For only fair evidence for provocation maneuvers, and there is limited evidence for imaging. So when they say that your X-rays did not show sacroiliac joint arthritis, you can show this. Tell them that there is no good evidence. But nowadays, the other day I saw a review, they refused the patient because it did show facet joint arthritis. So they didn't want to pay for that. Cervical epidural injections, there were 34 studies, 9 randomized and 2 duplicate studies. They met the inclusion criteria. Here, we were not able to use any non-randomized studies. Evidence was good for radiculitis secondary to disc herniation, fair with local anesthetic only, whereas fair for local anesthetics with or without steroids in axial or discogenic pain, pain of central spinal stenosis, and pain of post-surgery syndrome. If you observed that we didn't include, this is the lumbar interlaminar epidural. Here, we didn't include post-surgery syndrome. How many of you would do a lumbar interlaminar over caudal in a post-surgery syndrome and go through the scar? No one? Am I missing something? Thank God. Whew. So there were the evidence, on this one, there is good evidence for lumbar. The more recent evidence is good. This article is not published. It will be published in next issue of Pain Physician. So you can use all this literature to support your view and medical necessity indications. Thoracic interlaminar epidural injections, there is only one study, so it is considered as limited. These rest of them revisions are not completed. This is diagnostic accuracy and lumbar facet joint nerve blocks. It is good. Therapeutic, they have pretty much the same for medial branch blocks or facet joint nerve blocks and radiofrequency neurotomy. At the time we did there was limited evidence for intra-articular injections. I really don't think it is going to change much with the new ones. Thoracic discography, it is limited evidence, and there have not been any publications at all. Lumbar provocation discography, there are a lot of publications. This is a well-argued subject, and each year my friend Rick Derby used to come and speak here, but people were getting bored with the same subject, so we changed the subjects for 1 year. There is better evidence for lumbar discography. This is thoracic facet joint interventions. There is good evidence for diagnostic blocks. And for therapeutic medial branch blocks, there is fair evidence. There are no studies at all studying radiofrequency. Cervical facet joint interventions, there is good evidence or fair evidence for medial branch blocks, therapeutic medial branch blocks, and radiofrequency neurotomy. And there is no evidence so far for intra-articular injections. Cervical discography, limited evidence. Percutaneous adhesive lysis, probably this has better evidence than a lot of the other stuff we are looking at. Spinal cord stimulation, it has fair evidence in post-surgery syndrome and neuropathic pain, not for axial low back pain. Spinal endoscopic adhesive lysis, fair evidence, but nobody pays for that, so we don't have to do that anymore. Intrathecal infusion systems, right now the evidence is pretty limited in chronic non-cancer pain. Automated percutaneous lumbar discectomy, this has limited to fair evidence, so we have to look at it again with the new studies and everything. Disc decompression with decompressor, that is limited evidence. I don't think there are many new studies. Lumbar laser disc decompression, this is fair to limited, and probably there are a lot more studies now we can include. Nucleoplasty, there are a few more studies. I don't know if it will change the evidence or not. Thank you.